Welcome back, everyone. This is probably the most important part of PACHA's meeting at any full council meeting. We intentionally go out into jurisdictions across the country for this very moment. The idea that we have opportunity to have direct dialogue with you. Part of what we see is at the core of our work and our mission is taking back what we hear direct in community and translating that to new policy, new recommendations, and new action at the federal level. So it's vital, it's important. We take notes. We will be recording everything that you share. I have been tasked this afternoon to simply nudge some of you that I know aren't shy and share your recommendations and your expertise, but I don't think this group needs any nudging at all. No. Our conversation, I'm actually going to turn it over to my colleagues at OIDP who will directly facilitate, but we got about an hour. So some of you who think, oh, I got time to get my comment in, I'll let someone else go first. Don't do that. You go first. And this one already started. Right. So with that said, let's jump right into it. We are listening, we are recording, etc. So I will turn it over to Dr. Marissa and to Jill Martin, who will facilitate our session. Thank you.
All right. Let's clap it up for y'all for being here. Y'all made it to the best part. Well, there's been some good parts, but this is the juiciest part where we get to hear from y'all. I also wanted to say for those online, we will also be queuing your questions as well. So please just do the raise the hand function online and we'll be able to call on you as well. And if you want to come off mute, you can do that, or you can submit those in the chat. And then we also do have some Post-it notes. So if you don't feel comfortable coming on mic and you would like to just submit your question either anonymously or you would like the question to be given to a specific panelist, please go ahead. There are Post-it notes on either side and we can put a few out. All right. So without further ado, let's go ahead and jump right in. So how we'll do this is you can raise your hand. We would love for you to introduce yourself. If you want to say where you're from, your organization that you're representing here, and then you can ask your question. So I know you are first, Madame, so I will go to you first.
The queen, they didn't
excuse me.
Huh? Hi, I'm Cheryl Malone Thomas. So I have two hats. I'm faculty right across, UT, but I also work at the Houston Health Department. I'm a family nurse practitioner. So the first comment I'm going to make, thank you, we have you as our guest speaker for graduation. But anyway, the first comment I want to make is I want to see more funds and maybe an easier grant process for us to help nursing students. I said I was a nurse, but nursing students and medical students to help people living with HIV. Our curriculums are so crazy that we just don't have enough time unless somebody wants to do independent study. But they're the ones who are going to be taking care of us. So I don't think it needs to be that extra. It's not extra for them to learn about hypertension and all of the other chronic illnesses. So I want to see more dedicated to that. And I don't want it to be a 30-page grant that I have to fill out that all I want to do is say, can you give us some money so that we can help these students learn what they need to learn to take care of people living with HIV or those who choose to remain negative by taking PrEP. That's first. The next thing I want us to do with something is to teach them how to do that nicely. It's a big deal. And people, psychotherapy, I love psychotherapy, but psychotherapy starts when they come into the room with us, and whether we smiling or we're like, something like that. So and I'm not going to get on Mr. Moore because he's from Beaumont like me, but, and my kids are close to his age, but our younger generation, sometimes they're not taught how to be nice, even though they want to be a doctor or a nurse. And I hate to say that, but it's the truth. They are not. It's something that comes early on. So I want to be able to do like extra for them as a faculty, as a nurse practitioner, to kind of guide them in how to be nice. You know, I'm cute. My patients love coming to see me just because I'm cute. But, you know, if I wasn't nice, they wouldn't like coming to see me. But thank you. Thank y'all so much.
All right, I'm going to go here.
So yeah, you didn't have to pre-register. So if you want to,
You're okay.
Thank
Okay, we gonna come to online after this.
Thank you. So I'm Sheetal Patel. I'm an infectious disease physician here in Baylor. I wear multiple hats like most of us do. And I'm going to talk towards a few of my hats. And this session has been great. It's my first experience going to a PACHA meeting, but I've been in HIV care for 20 years. And I'm like, why didn't I know about this sooner? And I'm at an academic center, right? I could have brought students here. They could have learned a lot. So this is communication and getting more visibility of all of the resources that are out there, and then translating it to community-based organizations, to academic centers throughout our healthcare profession. So my provider hat. We talked a lot about how can we make change. As an ID physician taking care of patients with HIV, I am their primary care physician. I need more time. I cannot take care of anybody's problems, health conditions, mental health, sexual health in 15 minutes. We got to change the healthcare system. We got to do that. And if we want primary care physicians to help increase our clinical workforce, they need the time. I mean, I'm battling at my AETC hat, the AIDS Education Training Center hat. We are here to build capacity. We are working across Texas. And the primary care, like I have metrics to meet on diabetes. I got metrics to meet on cardiovascular disease. I got insurance companies telling me you got to look at drug-drug interactions. And you want me to talk about PrEP and HIV testing and sexual health in my 15 minutes? Not, we're at the bottom of that list. And I know this is not something new. It's just, where is the change going to happen? It has to happen in our healthcare reimbursement. Primary care physicians get paid so little compared to specialists, and we got to change that model, or people aren't going to go into it. Education in the health professional. So Cheryl Malone Thomas is one of 10 health professional faculty across 4 different health professional schools in Texas, in Houston, that are volunteering their time. And we put on an interprofessional education program every spring for students to learn about HIV care, but it's optional. The people who are early adopters come to that. I lead a course in my medical school. HIV, we keep getting less time in the curriculum. And unless we can provide funding, the only funding I get is to do IPE, interprofessional education. I cannot get funding to say, let me go talk to the curriculum committee. Let's create this new innovative way of doing things. I, on my own time, created a 2-week elective of interprofessional, like learning about interprofessional collaborative health. And if you read those reflection papers, that is what we need to do, because people really see what care for patients with HIV means. And we need to get more of that out there. But how do we do that? It takes capacity. It takes getting people interested and funding them to help do it. And then my research hat. I love working with community organizations, but we need more time because MOUs have to be set up. I want to put them on the papers, but we don't have time to get all those letters of support, all those MOUs set up before that grant deadline is due. I'll leave it at that. I have a lot of other ideas. But.
So I'm Jim Osborne, for those of you that I haven't met, Community Medical Liaison for Therotechnologies based here in Houston, and also immediate past president of the Board of Directors for Access Care of Coastal Texas in Galveston. However, my comment today is by proxy, and I'm speaking on behalf of Dr. Robin Hardwick. And so she asks, hi, I'm Dr. Robin Hardwick, and first of all, I am a nurse, specifically an HIV clinician, researcher, and educator, nurse practitioner, credentialed as an HIV specialist through the HANCB of ANAC and AAHIVM. We emphasize an urgent need and goal for ending the HIV epidemic. We are all well aware that we must identify those who are unaware of their diagnosis and link them to appropriate care. We are also well aware that we can prevent further transmission with PrEP. According to the CDC, nearly 136 million patients present for ED visits in the U.S. per year. About 30% of those ED visits among patients with chronic conditions are potentially unnecessary because they've not been adequately linked to care, leading to $8.3 billion in additional healthcare costs. On top of EDs being overwhelmed with visits, nurses are leaving the profession due to burnout from lack of support. 17% of nurses quit their position within the first year of their careers. A whopping 56% left within the first 5 years, leaving the average career length for nurses now at 9 years, was reported in 2023. While we're focusing efforts at advancing the understanding and developing better means of preventing, diagnosing, and treating HIV, we need to tremendously support nurses and provide the necessary resources to accomplish our goals. Point of care HIV testing should be available and standard of care to everyone seeking care in an emergency department from age of 13. Nurses should not require an advanced practice order to be able to obtain the test. Nurses should autonomously order and perform the test on patient entry. Nurses need the resources to support this plan. Education needs to be provided as routine to ending the epidemic and understanding the difference between opt-out and opt-in testing. EDs need resources. Not only should testing be standard of care to all, point of care tests need to be provided as standard. All staff members need to be trained on post-test counseling and linkage of care provided so that patients have an alternative site for care to stop using the emergency department for visits that can easily be managed by a PCP.
We're going to go online. So hi, Tana.
Hello, how are y'all doing today?
Come off. She muted.
Can you hear me?
Oh, 1 second. 1 second. We can't hear you. Hold on. Tana, try saying something again.
Hello, can you hear me now? Okay.
Go ahead with your question.
Hello, everyone. So it's more like a question, but it's also a concern from community. So I am Tana Pardia. I'm with Positive Women's Network, Greater Houston, and I am also an advocate, but also a leader here in Houston. And I want to say thank you to PACHA for listening to us here in Houston, but across Texas. I can't leave Texas out about Texas, but I am a woman living with HIV for 23 years. And when I think about the human rights of advocates in our concerns about MHS, molecular surveillance, HIV surveillance, we hope you will continue to stand with us in this fight for a fully funded HIV response and for full sexual and reproductive health and human rights of people living with HIV. Reproductive rights are under attack, especially for Black women in the South. Reproductive rights, and I'm going to say this again, reproductive rights are a human right. So I'm asking y'all to stand with us as community, but for Black women across Texas.
Hey, y'all. That's one of our leaders. So Vanita Ray, she, her, pronouns, Executive Director of Black South Rising. The main thing, and I couldn't be with y'all when I was on the panel yesterday, and I appreciate the feedback from you all, and I think the picture of Texas is pretty clear. You heard from a lot of agencies, but what I heard a little bit about today, Paul mentioned a few others that I want to really get to, is we cannot stop investing in the leadership and capacity building of our community. Folks can come to Houston now, and you could see here is 2024. Wow, they've got the Texas Strike Force. They got a legislator. Well, we've been, and I officially in 2014 started doing this work to build what you see now. Tana on the screen, who was Ryan White chair. We started in 2014 with a grant, a pilot grant from AIDS United for the People Organizing Positively, $40,000 investment, $20,000 to the agency and $20,000 to me to run it with no other job. Now, how I did that, I don't know, but yeah. So we have a lot of the leaders from those 5 years in here, and they have set the groundwork of what you see today. When Benton was talking about those bills finally making it, well, they've been out there fighting for them bills to make it to get here. They're the founders of the strike force. This community, we have, from that 40,000 investment, we were able to get other grants where we've been able to pay the community, because some of y'all are here being paid. These community members are working for free. And so then you need to be paid too. But you know what I mean? Y'all know what I mean, because I've heard, especially you, Maribel, I've heard you talk about this. And so we've gone after grants to pay these people, which I've never taken a cent of, for their time to do the work. Successfully, we've defeated a criminalization bill. We pushed back on our state health department. When Lindsay was talking about the 2,700 people, it wasn't Lindsay that got that. It was the strike force that had them change their spend down. They were going to just eliminate their spend down, and now they went to a standard deduction after a rule and comment period, the way it should have been done. We started building community and our capacity. We did our own EHE plan, ending the epidemic plan, here in 2016 before the federal government. And even though agencies weren't all in line with it, because the workforce they're not working to end the epidemic, they're working to get their grant deliverables done. They're working to, and one of the things that we've talked about in our EHE plan, we need to retrain the workforce on a broader vision of just meeting this grant, because that is not working cross silos. It's not de-siloing the effort. But another thing we did in that Indian epidemic plan, we started in 2016, our own, about racial justice and intersectional approach, which hasn't been comfortable. And we still have had to continue to talk about that. And while agencies were still so busy doing their own thing and wouldn't all come together to work and really implement this ending the epidemic plan, one aspect of it called for MEPA, meaningful involvement of people living with HIV. So we went on about the business of building our community while we were waiting on y'all to come up with us. So I want to tell you one quick short story. One of our women we started in 2014, and we ended with probably 50 to 60 something people, because everybody could come back every year, and they became the trainers. In the 5th year, they ran the program themselves. But one woman who was a part of our 2016 class called me and said, I just want to do it, but I can't be open, which you don't have to be open. It is not necessary that we disclose our status to do this work. That is a personal decision. And she couldn't do it. But it doesn't matter. We're going to work with it. That child is now the co-executive director of PWN. Okay. So she wasn't doing anything with this. Marnina, 2016, she joined POP. And because of community supporting her and building her and getting her into opportunities, not just me, because the whole community starts doing this when we start. You set an example. She now is co-executive director. Tana is on the board. We created several Ryan White Planning Council chairs, to which we just lost one a few months ago, and we're still feeling the loss of that. But so I just wanted to get at, everybody can sit here and take all these awards, which I want sometimes folks to just say what we didn't do right. I think we get more from y'all when y'all give us lessons learned than when y'all want to just always succeed. You cannot always put lipstick on a pig. If we can start with what we did wrong, we can do something different. And so I just wanted to say, while you all are thinking about this, don't forget about, and I know HRSA has a NOFO out right now about leadership of folks living with HIV, but we need to create a community. It isn't something you can do and graduate somebody from and think you've built their confidence and their ability to advocate. They need a community. And that's what we created here, that they're like family supporting each other, doing the work. One guy thought got diagnosed when he was in the operating room with AIDS, didn't know he had and got diagnosed in the same hospital. He came here to Houston to die thinking his career is over. He is now back operating tech, going around, just bought his first house here in Houston. Was it earlier this year? Carl. I'm saying his name wrong. Yeah, forgive me because I'm getting a little nervous. But my point is, we have now he's providing his own health insurance. He's doing it all. But we need to build the leadership and capacity of the community. Agencies can't do it without us. Matter of fact, that's why some of this ain't working, because you're trying to do it without us. So we can help this process, and we need the funding. We stop giving us a gift card for trauma porn. You know, if everybody in the room getting paid, we should too. If you're going to ask us to be talking about our story, everybody there is 6-figure, and I'm telling my most, serious thing of a diagnosis that was no small feat, y'all. It took me 4 years to get over mine. And every day I still have to, I get the baby telling my kid that the one grandboy around here, I had to go to the baby and say, you just told my grandson who I was. And that's not who I am. Don't do that again. So don't forget to build the leadership of those out here on the ground. We have been doing this, waiting on y'all. And we need all those pieces, the legislative work, the organizing work, the capacity building, training people how to monitor bills and write bill summaries. How do you get folks seeing what sparks them? I had one guy who wrote a play on Michael Johnson, who was criminalized, and wrote a play on him that we did at TSU. You know what? I didn't never produce a play, but we did that day. So whatever it takes, and it wasn't a lot, y'all. It was time more than anything. I worked for FQHC Legacy, and they have no idea what the amount of hours we spent in community space when they were gone. Because we did movie nights, we went to the food bank, we did toy drives, we did all kind of meeting up in there when them people were gone, because those spaces are community spaces, and if people knew that, they might be doing something in it. It's something that and we never let a case manager in our room. We never let pharma in our room, because I told people, it's your house. If they're not going to say something we want, why do we need them here? So we got to give folks that kind of autonomy, that kind of ownership. And I believe we can be those kind of full partners without this power imbalance that goes on when we're trying to work with y'all and we feel kind of sidelined because y'all the one at the agency is supposed to be the experts, but we have very much lived experience and subject matter expertise. And some of us have a professional life too that afforded us the ability to know some things. So please just utilize us and fund us. I know sometimes there's an assumption we can't understand, so we get to put in the play box, the sandbox, like we do in our Ryan White Planning Council. Affect the community, don't have no deliverables or no real something but greeting. And I'm sorry, but I'm gonna say it again. It is wrong. And you got a dedicated group, get them out the sandbox. They can understand.
Really quick, for those, when you share, we're just going to ask if you don't mind standing up when you share, if you're comfortable with that would be, and turn it back over to.
Okay, I have one Post-it, and then I'll go here, and then we'll popcorn around. Okay, so this is from Gloria from Texas Children's Hospital, and she said there are prenatals who leave grown and are now 30 to 40 years old, while there are groups that are senior living or older 50 years old, but there's nothing for perinatals who have aged. So just something to think about. All right. Mm-hmm. So we're going to start here.
At least 15 that I remember that you've been saying that. Yeah. So 15 years, that's too long to wait to get something done for folks that are, you want me to stand? That's right. Okay. So as people with aging with HIV, we do need more comprehensive health care services, sometimes even things that, that Ron White won't pay for. And so we do need access to health insurance. And so you heard me yesterday talk about how we even made a formal request as a part of the advisory boards to our Texas HIV medication program to use ADAP funds to purchase people health insurance. And they moved that up their chain of command. And when it got to the Health Insurance Services Commission of Texas, they said no. And so they weren't able to do that. Did they want to do it? Yes, they did. Because they see it as a cost-saving measure. And it's a cost-saving measure that we saw when we did it here in Houston back in 2014 or 15 when the ACA was rolled out. We did feasibility analysis. We saw it would save us money. We started with a pilot program. We saw it saved us more money than we even thought, so we expanded it. The Health Insurance Assistance Program with those funds for Part A. We advised the state to do the same thing, and they still haven't moved. They complain about not having the budget to maintain an ADAP, and yet they're not taking measures that are available to them to help them maintain their budget, like the expansion of Medicaid. So when you give them the choice, they're going to say no. You have numerous examples of that. You need to stop giving them this choice when it comes to things that we can control and not give them that choice. I understand that Supreme Court made a decision about women's health care access, and states could then do what they wanted to do. You saw what our state did. I understand that they could use, HRSA said, you can use ADAP funds to help people purchase health insurance. You heard me just tell you. We said you should do that. They moved it up. They didn't do it. I'm telling you now, you need a mandate that ADAP funds need to be used to purchase health insurance for folks living with HIV, if only in those states that have not expanded Medicaid. That we are trying to work towards more equitable situations. With the way that healthcare system is, it's already an inequitable situation in 9 states and compared to the others. Right there. We don't even have the ability to ask for a waiver from that 75-25. We need all that 75 for care because we don't have the support of Medicaid dollars. So I need y'all to do that for us. You need to mandate that ADAP funds in those states that particularly that have not expanded Medicaid, that they use to help people buy health insurance. As we age, we're going to need access to that comprehensive care. That's vital. And to piggyback on what Dr. Patel mentioned, we need more than 15 minutes. As we age and comorbidities, there's barely enough to talk about our HIV information when it comes to those 15 minutes. What about those other comorbidities that start popping up? We need more time. Influence the insurance agencies in ways that you can. Codify it in documents with the federal funds that we can use to make it a reality, at least for some, but it needs to happen. Right there. My mother was living with HIV, and if she were alive today, how old am I, 56? She would have been 75. Y'all were not ready for her. And barely ready for me. So we need to be ready for those other folks that Gloria's talking about too. It's way past time to be ready for them. So more than 15 minutes. Talk about that one. And just like Tana said, and I said yesterday, I want a moratorium on MHS, period. The time to talk was 5 or 6 years ago. And we tried, and we were ignored. We were told we couldn't do that. And so now the time for talk is done. Moratorium needs not to be happening in states like Texas, where you see people being criminalized just to get the health care they need. If they're women, if they have trans experience, a variety of scenarios. They're already being criminalized to get the health care to which they have a right. So when it comes to MHS, this is not the kind of environment in which you want to implement something like MHS. Do you really trust our state? Yeah. Do you really trust our state after what you've been seeing in the news and what we've been sharing with you? We don't. So I'm telling you now that MHS needs to be at least moratorium. From what I say, if people want to be more flexible about it, then some flexibility, but I say moratorium because the time for flexibility is already gone. After measures have to be made to build trust, that moratorium, MHS, would go along towards building trust with the HIV community. It'll prove that you're listening to us, that you've learned something, you've incorporated what you learned, and now you put it out there for the world for us to use. That has to happen. That's cultural humility, infused cultural competence. Lead by example. And as far as that leading by example, monitoring. Monitoring has to happen on a regular basis. I'm a person with HIV. I don't work for organizations. I don't care if y'all do it 2 years or 3 years. If you're giving somebody a 3-year grant and you monitor them in that second year, they have some corrective actions to do. They have a year to get things right. I'm sorry, federal government. That is an automatic renewal for that contract so that they can get it right with the recommendations you just made. Giving them a year, if they've just 1 year left in that contract, that's not good enough. Model your monitoring, lead by example. Show people what they're doing right, what they're doing wrong, give them the adequate time to get it done. It's at the end of the grant cycle. That's not on them. That's on you. And so you have to automatically renew that and help them get it done that right way that you showed them needed to get it done. That needs to happen too. I'll stop there because now I'm getting excited. Oh, because yes, Angela Davis, James Baldwin, that famous interview when things are happening in the 70s, when poor Angela Davis with the whole women's rights stuff, and then James Baldwin with being gay. The idea that if they're going to come for you in the morning, you're not going to be here for me when they come for me at night. And so we all need to stand up for each other. That's why you hear me talk about women's health issues. I'm not a woman, I'm a cisgender male, gay. So, but that's an important issue to me because they're still part of our human family. And so it needs to be attended to. I want to say there's no excuses, but it's not the right thing. It's not the right one. It's not about excuses. When I hear rationales that come across like excuses, I hear it as someone who doesn't have the will to get something done. So when things don't get done, I expect to hear an explanation as to why they were not done. So then we have new information when it comes to advocacy to try to get things done that we think needs to get done. I'm taking too much time in this mic. Here.
Okay, great. All right, we're going to go online first because we have a few people online, and then we're going to go here and then here. I saw some other ones here and then back. Okay, so and then we're going to come back over here on the East Coast. Okay, not really, but like fake. Okay, Frank, come on, Frank. I feel like a game show host.
Yes. Okay. Hello, everybody.
Hi.
Can you hear me?
Frank, can you speak up?
Yes. Can you hear me?
Yes, we can hear you. Go ahead.
Okay. Okay. Yes. Hello, everybody. Thank you for having comments like this for people living with HIV. Again, my name is Frank Rosas. I'm from San Antonio, and I'm glad to see that San Antonio was represented this morning by Cherise from SAFE. And I also want to acknowledge, kind of bring up a few points, which my friend and fellow HIV Medication Advisory Committee member, Stephen Vargas, mentioned yesterday and just today about the insurance issue. And I believe sitting next to him is also a new incoming Medication Advisory Committee member, Ms. Cordella Lyon. So we have some really, really good people on our Medication Advisory Committee. Stephen already mentioned about the insurance. And, you know, again, it's the Department of State Health Services in Texas, the HIV STI section. I mean, they are our friends and they want to make these things happen. But again, the Health and Human Services Commissioner of Texas is a political appointee. So, you know, it kind of goes up the chain of command, and then it's just this big wall, you know, that blocks everything. But, you know, that's really, really important. And I think with the Texas Strike Force Positive Women's Network that, you know, we're going to really push that at the next legislative session, you know, one of the issues next year. Speaking of Positive Women's Network, Texas Strike Force, again, I want to extend, you know, all my thanks. As a HIV long-term survivor of 32 years, and I was told that I was the first person to be living with HIV to be elected as the chair of the Texas HIV Medication Advisory Committee. Not to acknowledge that for myself, but again, about the principle of nothing about us without us. So, you know, it's very important that Texas ADAP, you know, they were kind of pretty financially stable until everything kind of blew up right before COVID. All of a sudden, we were like in about a $52 million hole. A lot of issues, mismanagement, people being directed to COVID and stuff. But make a long story short, you know, Texas Strike Force Positive Women's Network were made aware of the situation. They rallied people from across the state, and you know, they actually didn't ask. They told Department of State Health Services, we want answers. We want to know, you know, what exactly is going on. And so, you know, the director of Department of State Health Services, the assistant director, they actually went to, you know, a couple of virtual Texas Strike Force Positive Women's network meetings and kind of explained the situation and took questions from people. So again, but if it wasn't for those two organizations kind of stepping up to the plate and really pushing back, I don't think, ADAP would really still be in a hole. And so the other quick issues I wanted to mention was somebody mentioned yesterday that, again, it's, Cabenuva. We're one of the last states to actually not have that on our formulary. I also want to thank Lindsay Lanigan, who spoke yesterday. She spent many, many hours lobbying, and again, Texas Department of State Health Services hired an actuary firm to come up with figures. So their figure was it would take about 14 million to kind of put Cabenuva on the formulary, and Lindsay and other people kind of questioned that dollar amount. But another big issue dealing with ADAP, and I think that HRSA can also, if there's people from HRSA there that should look at, and I'm sure they've heard this before, is they made a policy clarification notice, I think about a year and a half ago, about the twice a year eligibility. One, self-attestation and every 6 months, and then again on your birthday, pretty much the same information, proof of income, identification, those kinds of things. But that really is a barrier to care for a lot of people to have to do this process twice a year. And I attended that online meeting when HRSA kind of announced this. Again, I think about a year and a half ago, and a lot of people just kind of assumed that, okay, HRSA said, we only need to do eligibility once a year. But then, the fine print that nobody really saw was it's still kind of left up to the discretion of the state. So, that's something that really, unintentionally, that I just feel like it's a barrier to care for many people. And how can we end the HIV epidemic if people don't have access to their HIV meds? I mean, so again, I know other people have comments and questions, but thank you for giving me the opportunity to speak. And I've really enjoyed listening to this PACHA session. Thank you.
Thank you. My name is Evelio Escamilla. I work for the Latino Commission on AIDS, a research associate. In my past life, I was a research grant administrator. So I have a little bit of background on grants. One of the things I always found really interesting, and I worked in an academic setting and in a service delivery setting. So service delivery settings are very different, of course. I hope that a lot of those service delivery grants that are going to the community are being reviewed by the community. Because they have a fair chance of getting, towards their geographic areas also, having good balanced geographic areas. The other thing is on the academic side, we got to do something about this indirect costs. We got to save money on that because we know limited funds are very limited on HIV research, and some of this indirect cost is really, really out of control. And so some of the things that we have to think about is really kind of balancing that idea of how to do that. Looking at funding more R24s and more R25s. R24s are center grants in academic settings. R25s is creating a pipeline of new academics, hopefully minority researchers, that can help deliver those future papers, those future research settings. It's really important to really create that pipeline. As something you probably found out that the workforce in Texas is very thin. So we really need to create those opportunities. I love when HRSA put out the paying for practicum $10,000 so they can get their MSW. That's a great information to kind of spread out and give it to other people also in the CDC. Creating those opportunities for training. We really need to work on the workforce. Having good, competent training, more minorities in those training centers, in those training opportunities, and more fellowships, more postdoc fellowships that can actually deliver some more outcomes.
All right, we're gonna go here, then there, over here, and then Okay. So we're going to keep these brief so we can try to get to everybody. So try to keep your comments nice and concise, and then we'll rocket fire. Let's go.
Okay. Hope Adams, Tarrant County Public Health. I have a couple comments. You kept asking about syringe exchange programs. There's only one legal one in the state, and it's in San Antonio. No one else can have one. Number two, our EHE program is partnering with universities in our area. So if you want more information, contact me. And then as a rural resident, HCA has come in and purchased our county health system, the whole system. They closed down every primary care clinic. They closed down every specialty clinic. They closed down physical therapy except for at the hospital, but you can't do outpatient PT at the hospital. You can only be inpatient. HCA is Healthcare of America. They are a huge conglomerate, private, for-profit hospital system. And so I am fortunate enough to work in Fort Worth, so I can come down to Fort Worth. It's an hour drive, and I get all my care here in Fort Worth. I'm not Houston. But if there's something y'all can do about huge for-profit conglomerates taking over our systems, our healthcare systems that are actually doing a pretty good job taking care of our rural community. And now in Wise County, there is nobody.
Hi, my name is Ravi. I'm a student over here majoring in health economics, doing a doctorate. Before I came here, I lived in small town South Dakota. So my question is, it's my first time attending a PACHA meeting. How do you guys end up in all these small town areas? I was just going through the stats. Texas is one area, one state wherein the HIV rates are high. But what about all these states wherein, let's say it's less than 100, maybe 200? How do you guys make sure that we attend to all of them? Just trying to understand, how do you make changes at the grassroots levels that can trickle up? Thank you.
Does anybody want to take that question? Or we can note it? Okay, we will come back to the. Oh, did you answer? Okay, we're going to keep rolling. Thank you for the question. We've noted it. And for the sake of time, we're going to keep going. Is that okay? All right, ma'am, over to you.
Good afternoon, everyone. My name is Veronica Brady. I am an assistant professor at the Cizik School of Nursing here. Thank you. I'm also a nurse researcher and a nurse practitioner. And I am going to read a statement on behalf or on proxy for one of my colleagues. And I'm going to read really, really fast, so hopefully I can get it all in. We are facing a critical juncture in this battle against HIV epidemic, not due to a lack of medical advancements, but because of a dwindling number of healthcare providers specialized in HIV care. As the pioneers of HIV care approach retirement, the influx of new physicians entering the specialty is alarmingly low. This shortage poses a significant threat to the continuity and quality of care for people with HIV, especially in rural and high needs areas. In this context, the role of nurse practitioners is both specialty clinics and primary care settings becomes increasingly vital. With their comprehensive training and patient care-centered approach, nurse practitioners are well positioned to fill this growing gap in the HIV care workforce. Studies have shown that nurse practitioners can provide care that is similar to or even better than provided by physicians, particularly in rural, underserved, and resource-constrained settings where access to physician providers is limited. Other studies have shown that patient-provider trust in care provided by nurse practitioners, greater there's greater patient-provider trust of nurse practitioners. This is crucial for maintaining the strides made in HIV prevention, diagnosis, management, which has significantly improved the lives of people with HIV. I'm going to skip to the close. The satisfaction levels and work conditions of current HIV care providers highlight the need for a sustainable approach to workforce development. Addressing dissatisfaction and remuneration and administrative barriers is essential. But so is strengthening the role of the nurse practitioner. By reducing barriers to their practice, we can ensure high-quality, resilient workforce capable of reducing patient morbidity, preventing new HIV infections, and contributing to a more equitable healthcare system.
Hit it.
Greetings to the committee and welcome to Houston. I am Evelyn Malone Hicks. My pronouns are she and her. I am an AIDS certified registered nurse. I am also an HIV therapeutic specialist for a pharmaceutical company, but today I am here representing as president for the Houston Gulf Coast chapter of the Association of Nurses in AIDS Care. We serve under the distinguished leadership of our executive director and PACHA member, Carol Trustin. Will my fellow Houston Gulf Coast chapter members please stand? You pay it, no matter if you paid your dues. Thank you. ANAC fosters the professional development of nurses and others involved in the delivery of healthcare for persons at risk for, living with, and or affected by HIV and its comorbidities. ANAC promotes health, wealth, and the rights of people living with HIV around the world. Inclusivity and collaboration among healthcare professionals are essential for providing high-quality patient care and creating supportive work environments. Nurses' dedication to inclusivity helps foster a culture of teamwork and mutual respect within the organization, ultimately benefiting both the patient and staff. We are indeed the most trusted profession in the world. The term nurse in the HIV care setting takes on many meanings. The culture uses the term nurse to encompass medical assistants, LVNs, RNs, NPs, and I'm so proud of all my doctor nurses in the facilities. Nurses take on the mantle of the full spectrum of care, from intake to prescriber to researcher and to administrator. We don't all look the same. PACHA, we are imploring you to include nurses in every level of all of your committees. Involving nurses at levels of HIV care and decision-making is crucial for the comprehensive and effective patient care. Nurses play a vital role in providing direct patient care, education, support, and advocacy. When they walk into that room, and as we've heard our other co-providers talk about 15 minutes, I can assure you nurses are there longer. Our holistic approach to care and expertise in managing complex health issues make us essential to the healthcare team in the HIV care setting. In discussions yesterday, there was a gap that was identified between the community and providers. As a nurse, I'm here to let you know we are filling that gap. It is our recommendation to please work to diversify your work groups to include the very provider that sees that patient from the front door back to their home. Nurses look different in the field. Closed mouths don't get fed on this boulevard, and we are asking to be a part of the team. Thank you.
Good afternoon, everyone. My name is Sofia Sepulveda, pronouns she, hers. I am a trans woman. I've been living with HIV since I was 25. I'm 47 now. And Yes, these are my recommendations. We need really the federal government to start legislating the same way that last administration did, which is through executive order. He did a lot of stuff to harm our communities that still the new administration is not taking back with executive orders. We also need the federal government to start telling our red states, and it might harm us a little bit or it might not, right? If they do not treat us with dignity and respect, the Black, the Latino, the LGBTQIA community, the federal funds should be withheld the same way that they told California when California said that they were going to be a sanctuary city for the immigrant community. Trump literally told them, if you do that, no funds will come to you. Why are we not important? Why are we not important? We need also the president to start remembering that he ran on a public option and then he turned away from the public option offer. We don't need adapt. A lot of times when we buy those insurance, we cannot even afford to go to those doctors because our copay is too high. Our medication is too high. We need to ensure that he goes by the promises that he made, which is running on a public option. I am sick and tired of living on the eye of the storm, of crying my eyes out every day because I don't know what our government is going to do to us the next day while y'all do nothing. I mean, when y'all release Title IX proposition, it was a joke. It was not protecting the trans community. It was telling you the trans people should play in sports, but if you believe that they shouldn't, then they shouldn't, right? We need the federal government to be more strict with the laws with the executive orders and the stuff that is pushing to protect our communities, because our communities, like Stephen said, we are vulnerable here.
Thank you. So we're going to go online. Oh, we're not going to go online. Oh, we are out of time. So online, folks, please write your questions in the chat, and we will be sure to get those to our PACHA members. Thank you all so much for playing. And over to you, Madam Co-Chair.
Thank you. Y'all give it up for Dr. Marissa Robinson. And we are moving this afternoon. We do have a hard stop because we want to be back in the room and reset ourselves. Dr. Admiral Levine wants to give remarks to Texas, to Houston, and to this PACHA Council right at 2. So we have a short break. We've got snacks in the lobby, generously provided for you all today by Gilead Sciences. Mr. Paul Williams and company are supporting us this afternoon. So please feel free, take a break, get a snack, reset ourselves, and we will start right at 2. Yes, please continue to send Post-it notes, continue to write comments if you have them. Those of you online, please continue to submit those. Thank you, everyone.
Produced by the U.S. Department of Health and Human Services.